If you have been or if you are going to be in the neonatal intensive care unit, then necrotizing enterocolitis is one of those things that you cannot miss to see. So what is necrotizing enterocolitis? What causes it? Why is it commonly seen in neonates or in preterm infants? And how do we diagnose it? When do we operate? And what are some of the complications that you anticipate? This is what we are going to cover in this video. My name is Benjamin and this is Med1Pager, and welcome back to the NICU series or the neonate series, where we talk about the different conditions that affect the neonate or the different conditions that are managed in the neonatal intensive care unit. So when we go to the gastrointestinal system, necrotizing enterocolitis is one of the most important conditions that we shall see in that sector. It's going to be an acute inflammatory necrosis of the neonatal intestine, seen mainly in preterm or very low birth weight infants. So what happens is that we have a progressing of the mucosal injury. We are going to have an injury that is first going to cover the most top layer of the intestines, that is the mucosa, and it is going to go ahead, penetrate into the muscles of the intestines, and if we do not check it, we shall go ahead and have a perforation, sepsis, shock, and death. And the hallmark of necrotizing enterocolitis is going to be pneumatosis, which is where we have air being seen within the wall of the intestine. So the core concept is we have a premature gut. That premature gut has a dysbiosis. The organisms that are living in that gut have not yet well balanced the way it should. Remember, we have the normal flora that prevents the overgrowth of other bacteria. Then we have the enterophytes coming into the picture. We are giving formula, we are giving this other food, and then all these somehow come together to cause an exaggerated inflammation, a poor perfusion, as well as intestinal necrosis. Don't worry, I'm going to expand on this picture when we look at the pathophysiology, and I'm going to explain how each of these come into the interplay. But it's very important that you understand this simple architecture as we begin. So when we look at the risk factors, prematurity is one of the strongest risk factors, and very low birth weight, especially when we have a weight less than 1.5 kg or 1,500 grams, then we are having a very much likelihood that that intestine or the intestines of that neonate are poorly developed. And very extremely low birth weight, especially below 1,000, it's almost inevitable. Formula feeds are also put in the picture, because think about it, these formula feeds can also act as feeds for bacteria, so they can lead to that overgrowth. Prolonged antibiotic exposure can lead to this, because it's going to cause a dysbiosis. It's going to kill the normal flora, the good bacteria, and then we shall have the bad bacteria proliferating. The dysbiosis has already been talked about. We can have hypotension or hypoxia. Whenever you have hypotension, there's going to be that ischemia, and then when you reperfuse, you get ischemic reperfusion injury. That's why kids who have had pathophysia, or kids who have had things like maybe they have failed to breathe spontaneously at birth, that's pathophysia, they go ahead and develop necrotizing enterocolitis in the days that follow. Then we have congenital heart disease. Again, this is a perfusion problem, so the intestines are poorly perfused, so they suffer ischemia. When they suffer ischemia, the integrity is damaged, and we end up in necrotizing enterocolitis. We have sepsis, whereby we have an infection. Sepsis can cause hypotension that results still in ischemia. Then we have polycythemia or severe anemia. These are issues now with oxygen distribution. With polycythemia, the blood is too thick, you don't have the red blood cells moving very well. Sometimes we have clotting, and when we throw clots, we end up with ischemia. So in a term infant, you want to always think about an underlying trigger. If it's a premature, we can say the preterm, we can say that maybe the intestines were underdeveloped, that's why they were at a higher risk. But in a term infant, they should be able to withstand this. And you want to think about triggers like a congenital heart disease being something at the back there, causing the poor perfusion and ischemia. Hypoxia, shock, or sepsis should always be at the back of your mind. So the pathophysiology in detail, we have an immature gut, and this has a decreased barrier or mucus. The mucus is low, which is the barrier to other things. We have an immature immunity, and we have an abnormal colonization or a dysbiosis. So what happens is that once you have this dysbiosis, you provide an enterosubstrate that can be the formula feeds, and when you provide these formula feeds, they are going to go ahead and lead to the overgrowth of gram-negative bacteria. And the premature intestine has an exaggerated toll-like receptor for activation. So these toll-like receptors, when they are activated, they're going to overreact to the liposaccharide, or that particular component that is found in the cell wall of the gram-negative bacteria, and that is going to trigger the toll-like receptor for activation, which is going to trigger the immune system. The immune system is going to come, and the epithelium is going to become collateral damage. So we have an impaired repair. Then bacteria is going to translocate further into the wall of the intestine, and once you have bacterial translocation, inflammation is going to take over. It's going to increase. You're going to have impaired mesenteric perfusion, and then you end up with bowel necrosis and intramural gas, which will always be seen on X-ray as pneumatosis intestinalis, which is basically air within the wall of the intestines. Then after having this air go there, you're going to have the transmural necrosis, perforation, peritonitis, sepsis will follow, and that baby is going to go into shock. So the high yield factor is that the toll-like receptor 4 are overactive in the premature intestines and promote epithelial injury. Now someone may ask me, why is it that we say formula feeds are going to be a factor here but not breast milk? Now the thing with breast milk is that it comes with IgA, it comes with maternal antibodies, it comes with those extra humoral immune system components that actually make it protective against these particular conditions. So when you look at the clinical features, what are we going to see in a child with necrotizing enterocolitis? Earlier on, they're going to get feeding intolerance. They're going to have increased gastric residues. When you maybe when you do a scan or something, you'll find that they have a lot of gastric residues. They're having a lot remaining in the stomach and not progressing downwards. They're going to develop vomiting, which can be bilious or not bilious, depending. They can develop abdominal distension and an increasing girth or the thickness. When you measure from top to bottom, the girth of the stomach is going to be increasing. They're going to have reduced bowel sounds because the necrosed areas are not allowing the movement. Then we are going to have occult or gross bloody stool. So you can see actually blood in there still, and this can be very, very scary for mothers. Then they can develop tenderness of the abdominal wall, erythema, as well as discoloration. So the classic features, you have a preterm infant with feeding intolerance, abdominal distension, as well as bloody stool. So systemically, they're going to have other features like temperature instability. They're going to develop lethargy, apnea, bradycardia, desaturation. That's the SpO2 is going to go down, or the oxygen levels in blood. The glucose is going to be unstable because they're not having proper digestion. And in severe disease, they develop hypotension, poor perfusion, respiratory failure, metabolic acidosis, disseminated intravascular coagulopathy, that's DIC, septic shock, as well as multi-organ failure. So when we look at the classification, we have what we call the Bell stages of classifying or of staging this necrotizing enterocolitis, and they're important because they're going to give you a picture of how your management is going to be or what you should do at that point. So we have the stage 1 where it's just suspected, and here you're going to have mild symptoms, you're going to have mild systemic symptoms, you're going to have feeding intolerance, and these stages are further broken down in stage 1A and stage 1B. In stage 1A, we have no bloody stool. The moment you see bloody stool, then you are already in stage 1B, and most of the times the intervention here is just we decompress them for like 3 days, give them antibiotics, and then do parenteral nutrition and correct everything else. Then when we have the definite stage, that is stage 2, here you have clear abdominal disease. The moment you start seeing that distension followed by thrombocytopenia or metabolic acidosis, then you know you have entered stage 2 of the bell stages of necrotizing enterocolitis. And here on imaging, that's when you are going to start seeing the pneumatosis intestinalis, or you are going to see gas, venous gas within the portal system, because as we have pneumatosis intestinalis, as air enters into the wall and we have that perforation going on, or that inversion into the wall, some of the air is going to escape and enter into the portal system, which actually drains much of the digestive system. So we have stage 3A, which is advanced, and we have no perforation. Here you're going to have shock, you're going to have respiratory failure, you're going to have severe acidosis, you're going to have DIC as well as peritonitis. So basically here you are having advanced features but with no perforation. That is going to be advanced neck without free air. Then the moment you start seeing free air, or what we call the Pneumoperitoneum, or what we call the Rigler sign, where you see air below the diaphragm on the side of the liver, that is on the right side of the baby, then you are going to know that you are in stage 4, or you are in stage 3B, which is the advanced or the perforated stage. And here we're going to have severe systemic illness as well as perforation. So the diagnosis, we're going to have the clinical and the radiological. And radiologically, you're going to have abdominal X-ray, and you're going to see Pneumatosis intestinalis, which is the classic sign. You can also see portal venous gas. You have Pneumoperitoneum, which is going to be a sign of perforation. Then on ultrasound, sometimes you can see the bowel wall thickness. You see the wall of the intestines, how thick it is. And then sometimes you can also be able to see the air, which is pneumatosis, as well as portal venous gas, free fluid, and complex ascites. So when you have absent perfusion plus complex ascites, then you have a high concern for necrosis. The labs, you can do the full blood count, you can do the platelets, you can do the CRP, the blood cultures, the blood gases, lactates, electrolytes, glucose. All these are going to be deranged in different ways. And the most severe features, or the most bad labs to have, is if you have falling platelets, then you know things are not doing well. If you have persistent acidosis, you know things are not good. Rising lactate, things are not going well. Neutropenia, hyponatremia, then you know you are going into severe necrotizing enterocolitis. And some people say if the lactate is rising as well as platelets falling, then you know you have a high risk, or there are high chances that you already have a perforation. So the management is going to be simple: stop feeding, decompress the stomach, give antibiotics, support, and monitor. That is the principle, and it's going to be done most of the time. So you want to maintain nil per os. Then orogastric decompression can be done, and then switch to IV fluids, correct the hypovolemia, correct the electrolytes, and also the glucose, as well as for shock. Then give broad spectrum antibiotics that are covering both gram-positive and gram-negative. Then you want to give total parenteral nutrition if there is prolonged bowel rest. Most of the time you're going to do this in stage 2 of the bell. So when you're giving this, make sure you're correcting things like anemia, thrombocytopenia, coagulopathy, as well as DIC, doing serial abdominal examinations. You want to see, is my abdomen going down? Is it going up? That's the only way you're going to know if you are making progress in the right direction. And early surgical review is very, very important, even before perforation, if the baby is deteriorating. So when do we operate? The absolute indication is when we have pneumoperitoneum. This is whether in adults or in children. Once you have perforation of the peritoneum, it has to be repaired. So strong indications is if you have a strong metabolic acidosis and rising lactate, refractory shock, falling platelets, abdominal wall discoloration, peritonitis, fixed bowel loop, complex ascites, absent bowel perfusions. All these things, all these are signs that you need to operate, or there is pneumoperitoneum, or there is perforation. Then the surgery that can be done, we can have a laparotomy, which will remove clearly necrotic bowel, contamination, and preserve the maximum viable intestine, because you don't have to cut out a lot of the intestines. There is that risk of short gut syndrome or short bowel syndrome that will develop with people who have had resection of the parts of and anastomosis of parts of the intestines. Then we have a peritoneal drain, which is selected for unstable, extremely low birth weight infants as a temporizing therapy for occasionally definitive management. So sometimes we can put the peritoneal drain to try and reduce on the contaminants because we are not able to do the surgery yet. But as you can tell, of course, the prognosis is going to be very, very, very poor. So complications, we have the acute complications and we have the late complications. Some of the acute complications, we have intestinal necrosis, perforation, peritonitis, sepsis, septic shock, DIC, respiratory failure, as well as multi-organ failure. Then the late complications, we can have intestinal strictures. This can occur weeks or later, and you can see things like distension, vomiting, intolerance, or even obstruction developing again. We can have short bowel syndrome, which can come with its own problems like malabsorption, chronic diarrhea, nutritional deficiencies, growth failure, dependency on total parenteral nutrition, as well as intestinal failure associated liver disease. This is because as you give TPN for a long time, there is that chance of developing liver disease. Sometimes TPN also causes cholestasis because we are not having things moving through the gut, so we have a buildup of bile and gallstones develop, or cholestasis. So high yield associations, prematurity, the strongest risk factor is going to be prematurity is the strongest risk factor for necrotizing enterocolitis. Breast milk is protective. Pneumatosis intestinalis is the classic sign. Portal venous gas is a sign of significant intestinal injury. Pneumoperitoneum is the sign of perforation or surgical disease. Falling platelets and worsening acidosis plus rising lactate is a sign of progressive bowel necrosis. So we have come to the end of this video. My name is Benjamin and this was the neonatal series. We're still covering a few more topics left that are very, very important when it comes to managing babies in the NICU or the NICU rotation. Let me hope you have subscribe to the channel. If you have not subscribed, then please do so. My name is Benjamin. Let's meet in the next video.